If not, is there a motion that the minutes be approved as submitted? Dr. Varma, second. Second. Craig, Bruce, all in favor? Aye. Aye. Opposed, same. Minutes approved as submitted by unanimous consent of the body. Next, we will go to information and discussion. We will have a health coalition report by Dr. Brian Carr and Dr. Linda Bryce.
Thank you very much for giving me a few minutes, and I'm not going to take most of it. Dr.
Whatever amount, however you want to divide it is fine.
As a nurse in this community and as a public health educator, I guess I want to speak just a couple minutes about the personal part of what's going on here, about the people that's been involved in that. When we talk about the fact that on 30 August, the health department was closing the door, but the people who worked there, some of them for 23 years, they received notice way before that their jobs were no longer in effect. And on 31 August, they were going to, their jobs were going to end. And the contract was not going to take place until, or even speaking about it, until the 8th of September. And which means that there was going to be a time frame that there was nothing that was going to be taking place for those individuals in the community. And it's not like you can just say that the health department closes today and the new sections, subcontracts can open up tomorrow. There's a lot that has to go behind the scenes to get those individuals and those places ready to go. And I know in some of the instances they were having to find new locations to even set up what they were going to do. But part of what I'm worried about is the loss of all the expertise that's been at the health department for a long time. Unfortunately, tomorrow is Jamie Parker's last day. She has been the individual who has been the stalwart, trying to keep the STD going for the last 13 years, and her expertise is going to be lost. And that was because when she was told that her job was no longer, she had to find someplace else to go. We have other individuals in both immunizations and Becky and that have been there 22 and 23 years. We can't afford to lose that expertise because you can't just go and say, okay, tomorrow you're going to take over this position. It takes a long time to get somebody up and going on these specialties. So, that's one of the things I wanted, to make sure that everybody realized that we're not just talking about a building, we're not just talking about money, but we're talking about people who've dedicated their lives to serving this community, and you can't just turn around and subcontract it to somebody else who's not had any training. So, I just want to keep that in everybody's mind that there are people involved, people who care deeply for this community. And if we totally close and subcontract, these other organizations may or may not be, take these individuals in because some of them have already sought jobs otherwise. Thank you very much.
You're welcome, Dr. Carr.
Well, I appreciate this opportunity to present some of the research that the coalition's been bringing together to better define and understand the issue. I can tell you that in some ways I lament that having been on the board for 18 months and now having taken an extensive crash course in public health, I realize how much I didn't know about public health and how the board, I believe, will benefit greatly as we all have gone through this process to try to understand what's going on. I'll tell you that the coalition, we're coming at it from a different direction than I think the city has. And so we have two philosophies. And we have the philosophy of budget, we have the philosophy of taxpayers, and then we have a philosophy of preparedness, and one could say humanity, compassion. And I think that they're fundamentally two different philosophies. And so the difficulty is that they both have merit, but then to try to navigate our way through this and to ask ourselves, how do we feel about public services and the essential role that they play, or are they essential? We would argue that the police and that the fire, those are essential services, and that we would never say, it's really too expensive to patrol the north side of Lubbock, So we're just gonna cut out all that. We can't afford fire stations, so we're not going to have that in the southwest level. I think what would happen is we'd say, well, we need this, and we will have to find the funds. And so it's not the purpose of the coalition, nor do I think it's necessarily the purpose of this subcommittee, to be the money people and to say, here's where we found the money. I think that we have to attack the broader debate and say, these are essential services, and then challenge our city staffers to tell us where the money is available and what else we might want to do. Now, I will note that the coalition has a much broader review of public health, but in deference to Dr. May, I will only speak to 3 of those, even though I believe that you may have gotten the submission from me of our working draft, which covers all areas of public health and concerns that we have, but leave it at that. I think a good place to start on what Dr. Bryce talked about is that health promotion and protection is far too often equated simply with provision of medical care. And I think that's part of it, is that we're having an argument of saying, well, if we, as long as we give immunizations, that's public health. And I think as you look through the paper that I prepared, that clearly that's not the role. For example, to understand that STDs, that the reason that public health treats STDs is a means to an end. It's not so much that they want to treat the STD as it is that they want to go out and interview and contact and talk with the individuals and the partners so that we can deal with the health problem. And so we're looking at a much broader part of this. And I think that it's interesting that in the article that I found on the website, Dr. May had asked us to look at the news release about programs, health departments across the country being cut. There was a wonderful article called Operational Definition of a Functional Local Health Department. I also emailed that to everyone today. And I'd encourage you to look at it, because this goes directly to the heart of the contention of the coalition that by the actions that are proposed, we will in essence have a health department primarily in name only, and it won't function. And this is actually well supported in this document. So I would encourage you to look at that and understand that this is one of the accrediting larger national bodies. And as you look at their standards, we won't meet their standards, particularly in the area of health education, because that's a big part of it. Health education, whether it be food safety, whether it be other code safety, it's about educating and not simply having a checklist that says check, 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 food is hot, food is cold. You need to have people educate about why those things are there. Now, again, I would just mention that in these 3 areas, that if we look, for example, at health surveillance, that their public health action involves investigation and control, planning for a factual base for rational decision making, and evaluating preventive and control measures, as well as generating hypothesis and stimulating public health research. Can 1.5 people do that for a city and county the size of Lubbock County? I think anyone can look at that and say that would seem to be quite a challenge. And some of this is, I think, what's going to happen, and again, my concern, or as we talk to the county and other people, is to say that the city will offset some of their costs directly onto the county. Only thing, if we do, think what would happen if that Hep A exposure, if that would have turned into a true epidemic, then we would have had 2,500 people that came in and gotten shots, but then we'd have to track down those other people. And again, think about how well can 1.5 people do it? Well, I would think that they can. That you'd have to hire outside people. You'd have to hire or pay overtime to first responders to help administer the programs. So your costs are going to be astronomical when you do it that way. And I think that there's a direct analogy of saying public health is our invisible friend, and we need to have it there and it's ready and not after the fact. The people in New Orleans knew that the pumping stations were inadequate to the task. They knew it for decades before Katrina hit. And afterwards they said, how could this have happened? Well, because we didn't have the money to fix those stations. And so that's the fear I have, is that if you look at outbreaks such as measles, hepatitis, flu, or pneumonia, for example, as Dr. Reed pointed out prior, we don't have enough respirators in this county, and they can be taken and allocated elsewhere. And so do we really want to have citizens who aren't able to get needed necessary services because we haven't prepared for it? So I think that when things are good, we can all say, this is great that we have a public health service, but then when it really hits the fan, I think we can realize that it may not be adequate. Same thing with STDs. Dr. Bryce is commenting about, you just can't bring someone in and say, you're now in charge of STDs. You have to train them. And so that's going to be an expense to do that. And again, a nonprofit is going to go out and do educational programming. Are they going to go out into the community? Do they have the time? Do they have the resources? our location and we'll treat you. But we know that, again, the best health programs are the ones that reach out into the community, which falls then into immunizations. I'm saying the immunizations that go out into the community will help those grades. And for every flu vaccination that we give, we save $87. For every pneumonia vaccination that we give, we save $187. And yet the compliance rates are only about 60% for whites, about 45% for Hispanic, and about 30% for black. And so we're leaving people out there exposed, and those costs are going to come back. Because when you have a seasonal flu that blows through here, or pneumonia that blows through here, those costs are going to come back to us. So I just think that the whole idea is we want to be prepared and ready for that. And this requires an integrated service, particularly these three services. But then beyond that, I think we need to look at expanding other areas. And our coalition is proposing that we form a 501c3 to go after additional money for educational programming that takes it off the backs of the taxpayer, so that we can do those things that are absolutely vital to our public health. And so there are ways to get additional funding, but again, we're in such a rapid movement forward, as Dr. Barman has said in his emails, that we need to get to some point of recommendations. And of course, one recommendation is I think we're running out of time and we're nowhere near done. So our coalition is going to meet after this meeting to continue our drafting of a proposal. We have several recommendations in here that you can look at and decide if any of these fit and are worthy of consideration by this committee. And we will continue to look at this at the Board of Health. And so all I ask is a consideration of this, is look at the facts, and to realize that in the end we can save money by integrating these services, and we will spend money by farming these services out, and we will put the citizens at risk for failure to keep this integration of public health. Thank you.
Dr. Carr, thank you. We're going to have about 5 minutes for questions for Dr. Carr. I have one right off the top. You mentioned respirators in the county. Respirators are a device that filters out things like spray and powders and such. Did you possibly mean ventilator?
I defer to my medical colleague.
Well, you were talking about a device that Dr. Chakru would be the person to
I don't think Dr. Carr is referring to ventilators with people who put them on. I think he's referring to people,
protection mask?
Protection mask is what.
You're talking about a protection mask, not a.
Yeah, I think whatever would be the resources allocated to a epidemic of pneumonia.
I think that they were talking, or I think that he was talking last week about ventilators, and if we had numerous people, especially the elderly and that, needing to go on ventilators, that there's not enough around.
Yeah, no, I'm sorry, no, who was referring to that?
Ted Reed, Dr. Reed had mentioned that the current number, as he explained it, of ventilators, if there were to be a sudden spike in the rates of pneumonia, that we might find ourselves with insufficient number of medical equipment.
But we had that issue like 2-3 years ago when we had the H1N1 epidemic. We don't keep 100 more ventilators because it's big, but we were able to find those ventilators. When you need them, we can always bring them. We have companies that will help us in case of emergency. So that
Because of course, if it's statewide or nationwide or international, all bets are off. We're gonna be on our own.
During an emergency, there's public-private cooperation. For example, we can go to Walmart and enter into mutual aid agreements with those who, if during an emergency we need water or medical supplies or whatever, they are able to do a certain amount. And with several different private partners, we can specify exactly ventilators or breathing masks or penicillin or whatever. And usually those partners will have in storage, and they're responsible for the shelf life, et cetera, to meet the demands of the public.
Leanne, you had a question, and we're gonna take some extra time. Dr. Hickle is not here today, so we will have some extra time for questions and answers, so we're not at all pressed. Leanne?
If I could respond to that, going back to the presentation that the deputy chief provided last week. When we run out of local resources, and it is a city-county emergency management plan, and we have recently done a city-county COOP plan, which is for continuity of operations. When we run out of local resources, we go back through the State Operations Center, which is managed by the Governor's Division, and whether that's medical equipment or it's bulldozers, the state assists in getting those items to us. If they do not have it as a state, then they work with their interlocal agreement, their interstate agreements that they have with the surrounding states, and we've done that at a state level with fighting forest fires, for instance. That process is in place, and we do that through emergency management. And that's all hazards.
That's all hazards through emergency management.
Yes, sir.
Other questions?
Well, again, a question I have for Bridget would be, so we know that the main reason that people don't get vaccinated is because of lack of information. If these services of immunization are farmed out to these nonprofits, will the nonprofits be required to demonstrate that they will carry out vaccinations in non-traditional settings? And what is the effort that they will be responsible for in terms of outreach, health education?
Okay, yes, those will be required because those are part of the grant. The city receives the grant. Should we subcontract that grant out, we would still have to make sure that all of those grant deliverables were done. And we would have to be accountable to that, for that, to the state. And there are requirements for outreach and how to do clinics. So we would have to continue to meet those.
Have those been done? So how is health education handled in the health department since we don't have any educators?
Well, we do, that's part of the immunization grant is education. They give us materials, they tell us how to educate, that's part of what we do is educate.
Can you tell me, if you're familiar, like, so if these non-providers or nonprofits are called for to do non-traditional, how frequently, what kind of locations, do you know?
Well, I'm not sure what you mean by non-traditional.
For example, I found citations of public health departments that would have, for example, vaccinations made available at health fairs, at rock concerts, at sporting events.
They don't dictate exactly how we do our outreach, but I think we've done a pretty good job of being innovative, like having drive-through things. We do health fairs, we go to the mall, we go to schools, so
But
we do a lot
these
of
nonprofits will be required to do that in
Yes,
some form or
because that
fashion.
is a
But we don't know
requirement.
exactly what they may or may not do.
No, but we can provide direction because we are overseeing the grant.
Now, a second question I have is, do you recall that I asked you at a Board of Health meeting that although the price of vaccines are fixed under that grant, that you said that you felt like that the health department would be at the bottom end of, or is at the bottom end of that range, and that if these vaccinations are transferred to a nonprofit, you felt that the cost would probably go up to the upper end of that range. Do you recall
That's-
making that statement?
Well, not exactly like that, but the adult safety net vaccines, I'm sorry, the private pay, yes, those, there's no cap on those and any price can be set. But if we're overseeing the grant, we can strongly encourage, that they keep things the way that we're
on folks who might have insurance, might have Medicare, or have
Yes.
the ability to pay, and they would also have the ability to get their shots at Walgreens, at CVS.
Absolutely.
Okay.
Can you give me an idea if the nonprofits, when the money's flowing, they flourish? What's gonna be our strategic plan if they turn around and say in 3 or 4 years, you know, this is just getting to be too much of a hassle, we're not gonna apply for this grant anymore? Does the city have a plan?
We're not even
We're not even
convinced
sure.
that we'll have grants coming in from the state of Texas to even offer out as a subcontract. I don't think any of us, unfortunately, nobody knows what the state will do next. And I think we have to be prepared that may come down
Right,
to
so that's my
us.
question, could you elaborate on how we're prepared for if these nonprofits or someone else says, we're not the clinic of last resort, they hand it back to you?
It's the same question that the city would face whether we're subcontracting it or whether we're doing it ourselves. The question
doesn't
will
matter.
remain the same.
So what's the answer? So they do that, and now we're in a position where we've got,
I don't think we can answer what the city's going to do with a particular program 3 or 4 years down the road when we don't know what the state is going to be providing to us.
We don't know what the federal government's gonna be doing either with Obamacare and other factors, so it's not useful to conjecture at this time. We can only deal with what exists at this time. Other questions? We'll take a couple more minutes here. Dr. Bryce, did you have any other comments?
I think everything's.
Any other questions for, yes, Dr.
Just a
Chakuria?
comment, Mr. Chairman. I share Dr. Park's concern. What I would like to see this committee do and the city council and the board of, we have wonderful people with a lot of expertise. We have Richard Park, who runs Covenant, we have Greg Rose, who runs UMC, we have Randy Pickett, who's not. These guys have expertise. They can help us see how we can run these 3 programs. I still like to see all these things done under one facility for all the reasons that you mentioned. So let's give an opportunity for all of us to work together and see if we can still provide these services in one facility with the resources we have. If we can't do it, then we look at all the other options, and then I'm open to other options. But I still like to, let's work like partners and goodwill. Let's get this done. I still have hope we can provide these services in one, we can find a smaller facility. There are medical facilities available we can use with the resources available. Let's do the best we can, see if we can provide them in a smaller facility, in an effective way, with the resources we have. If we can't, we'll look at the other options.
Good. One more time for one more comment or one more question on this section. Yes, Dr. Bryce?
Bridget, I just have a question for you. I think is it Diane that works with the TB patients and to follow her? Is that gonna be part of the immunizations, subcontract? Will somebody be monitoring the TB patients?
We'll still have the same services that we provide now.
Will that go with the subcontract or will it go with Becky?
I'm not sure if we're going to subcontract, but if it did, that would go with it.
Okay, that's what I want. Cause I wasn't sure, it was a question as to who was going to do that or not, if that was gonna be part of the subcontract. Thank you.
Okay, we've taken 25 minutes on this section. Let's go to the next section. Greg Bruce, University Medical Center.
Thanks, Dr. Bank. At our first committee meeting, wow, that's long. At our first committee meeting, questions were raised about the role of the county hospital district in providing indigent services. We provided a summary of our costs, not the charges, but the true costs of the hospital district, and that's under Appendix L in your book that you had. Let me just briefly review some of those and summarize them. For 2011, we estimate Lubbock County unreimbursed healthcare items will total $53 million. This is up from $47 million in 2010. For 2012, we project that will increase to $59 million. We also provide unreimbursed healthcare for out-of-county residents. In 2011, this will be $20 million and projected to increase to $22 million next year. We do receive tax revenue, disproportionate share, and overpayment limit funds to help offset the cost of unfunded care. However, a funding shortfall remains, and the net cost of unfunded care in 2011 is $25 million and projected to increase to $31 million in 2012. A recent report from the National Association of County and City Health Officials show that more than half of all local health departments cut their public health programs between 2010 and 2011. More than half reduced or eliminated at least one program, with maternal and child health services leading the way. The report concludes also that the worst is yet to come, with 52% of local health departments expecting further cuts in the next fiscal year. The issues facing Lubbock are not unique to Lubbock, but I believe our approach can be. One of Lubbock's strengths is our ability to respond to challenges and work on creative solutions. In 1967, the citizens of Lubbock had a vision for a medical school. They voted to create a county hospital district to help facilitate achieving this goal. It is hard to imagine in today's environment that voters would ever elect to tax themselves, but that's what the voters did 44 years ago. The result of that forward thinking is the Texas Tech University Health Sciences Center and UMC Health System. Over half the doctors in Lubbock today were medical students, residents, or faculty members at TTU-HSC. Lubbock has a strong medical community and we work very well together. Covenant Health System, Lubbock Heart Hospital, Grace Health System, North Star, the Community Health Centers of Lubbock, UMC Health System, and others are committed to working together and supporting the healthcare needs of our community. I believe the City of Lubbock does have an important and key responsibility for coordination and management of health issues. While the health department does not provide primary care services, they do have an integral roles in surveillance, STD testing, immunization, disaster preparedness and response, and other public health functions. When this community is faced with challenges, I believe we respond with positive solutions that work. This is why I say our response to a nationwide challenge of healthcare budgets will be unique. In 2005, when evacuees from New Orleans arrived in Lubbock, it was not a city-led response. It was not a Red Cross response. It was not a Health Sciences Center response, Covenant, or a UMC response. Instead, the community worked together, and it was a Lubbock response. It worked well, and is something the entire community took pride in. I know Lubbock will do the same in this regard. The interest and engagement of the medical community, as well as the community as a whole around this issue, is encouraging. I believe the City Council will have the support and energy of countless people. We are goal-aligned to do what is best for the public health of our community. Both Dr. Bryce and Dr. Carr have raised legitimate concerns and questions. I appreciate their passion and know these will be issues the Board of Health and City Council will consider as they move forward. The budget challenges faced by Lubbock are the same communities nationwide are facing. The city's central role in public health cannot be abdicated. The city manager's proposal to subcontract immunization and STD delivery functions maintains the city's central role, and oversight of these functions will remain with the city. The city manager's proposal is one possible response to the challenge. I believe that reasonable people can come to different conclusions when evaluating responses. I also believe the city manager and city staff are the best equipped to evaluate and recommend to the city council. It is the role of the council to implement and continue to monitor the decisions that they make. The staff have provided us information that have shown clearly that they have reviewed many options and that they're continuing to review options. I believe that the city manager's proposal is a sound option that preserves accessibility to services and preserves the city's oversight role. I believe also the council should consider it. The council should also request a quarterly review of these functions by the Board of Health. If changes are needed, the council can evaluate this need based on the board's recommendation. Nothing should be set in stone. The City Council and Board of Health can continue to count on the support of Lubbock's hospitals and communities that are represented here today. We're all working together. I am hopeful and convinced the community as a whole is up to the challenge of supporting public health efforts, just as it has demonstrated countless times over our history. Thanks, Dr.
Thank you, Greg. Questions, we're open for questions. We have several minutes. Any questions, any comments?
Greg,
Dr. Chikuru.
you may or may not have all the information you need, but given the information and data we have, do you think, and maybe Richard can help you in this regard, do you think we have enough resources to provide all these three services in a smaller facility in an effective way, not go with the contracting outside?
I don't believe I'm probably the best equipped to answer that. Again, I think that the city staff and city manager are best equipped to say how they can provide those services. I know that they have looked at options, as the city managers told us in prior meetings, examining any resources that they currently have in place, and I believe they've also looked for other options and continue to look for options. From my position at the hospital, I really can't evaluate if the city has the resources available, if there's space available to house those in one place. One thing to bear in mind, that even if space were found available, a lot of the savings are associated with decreasing overhead. And if we were looking at another space, there would be some overhead expenses that would be layered on. There would be the potential of rent. There would be certainly utility costs and other costs associated with a central facility that are part of the city's decision to reduce, and the result of the city's decision to have the savings generated is by eliminating those overhead expenses. So really, I think the city manager probably would be better equipped to answer if there's any options available that she knows of for central housing of these facilities, of these services.
Dr. Carr.
Who do you believe should be the entity of last resort for public health services in Lubbock? UMC? Who's the bottom? Where the buck stops?
You know, Dr. Carr, that's an interesting question. I think we all have a responsibility for that. Covenant Health System also provides services to indigent folks. They also provide uncompensated care, as does Grace, as do other providers in town, as does the hospital district. I think it's a shared responsibility that no one entity can step up and assume. That is one of the goals, I think, that the city had, that the residents of this community had in 1967 when they created the School of Medicine, is to provide training for providers, both doctors and nurses, that would meet the healthcare needs of this community forever in the future. And I believe we're all working together in that regard. I don't believe it's the responsibility of the city solely. I don't believe it's the responsibility of the county hospital district or Covenant. I do believe it's the responsibility of everyone who's working in healthcare.
Do you have a concern that with a diffusion of responsibility, such as saying we're all responsible, could it be a possible problem of in the end then something happening and we discover that we're all responsible but no one in particular is responsible, and so the reason that public health needs to stay as an essential government service is because in many ways government represents the last resort?
I believe government has an oversight and coordination role in public health, and that's the role that the city health department has performed over the last several years, and it's the role that they will continue to perform. I think that the oversight and management and coordination of public health is the city's responsibility. I don't think it's necessarily the city's responsibility to deliver those services if they can find other means that are efficient and accessible to the citizens to perform those services.
Do you believe that clinicians should play a part in managing clinical services?
Can you clarify that question?
For example, I ask about it, if these RFPs go out, I ask who's on the review committee for these RFPs, and was told by a representative of the city manager's office that, well, it'd be people from city management, budget, contracting, and I said, who clinical reviews those? And I
There's
was told,
certainly, again,
no.
I don't think I'm equipped to answer that question. There's state laws and other items that are affiliated with the procurement process. Judge Medina could probably better address that than I can.
Sam?
Dr. Carr, I think you hit it right on the head. There are procurement processes and procedures. There's also requirements of law. There's also the way not only the council, but everything from our charter, everything that sets that in place. And so certainly recommendations can be made to a board, they can be made to anybody, but the actual process is set already. And by law, we're gonna have to follow that process. And it's not just necessarily inviting the public to come in and do it. I mean, it would never get done necessarily.
Any other questions or comments from others on the subcommittee?
One of the comment I had on the
Yes,
procurement
Bruce,
process,
yes.
one thing I think is good is we are looking at grants that are given to the city by the state, and there's certainly stipulations in those grants about how the grant funds are administered, and certainly you have a kind of almost a checklist. Dr. Carter, if you go back and administered effectively. So I think that we already have a roadmap to determine if this is being successfully administered, and we can evaluate that, the council can evaluate that and determine the most appropriate things to do in the future. Yeah, I really don't think anything should be set in stone, but look at the way that we provide services the best for the community.
And you brought up a good point, Greg, I think, using the resources we have as best possible, because none of us know how much cutting is gonna come in the next couple of years. I think we need to look at the fact that we're gonna have to be leaner and have less funds, and setting up these programs so they don't get cut, but so we can continue to deliver them and handle them is going to be very important. If we have a weighty infrastructure, we simply may not be able to support that infrastructure, and overnight we may have to shut it down, and that's one of the things that we want to avoid.
Yeah, certainly, Dr. May, I think that the one constant in healthcare provision, whether it's at the hospital setting, the clinic setting, or a public health setting, is change. And we're going to have to be able to adapt and respond quickly to that. And I think that is going to call for the council to be very involved on evaluating and monitoring this process as they go forward, regardless of what option is selected.
Absolutely. Anyone else have any questions?
I just have one.
Yes, we've got two other people. Yes, Dr. Presley and then Dr. Bryce, so we'll have to go on to the next.
First, I applaud what Dr. Carr said about the Health Coalition forming a 501c3, private money. That's great. That's a nonprofit. But I'm thinking while I'm hearing Greg talk, you know, if there was, once again, I'm going to state it, Dr. Varma, there was never an intention for these services to go away. It was just how they were going to be delivered. But if these grants go away, and I don't know the answer to this, if the grants go away next year or the next year, do these services go away?
That's going to be up to the city council. We don't have an additional revenue source coming in behind it that will take care of that additional service.
And that's what I'm pointing out here, is we don't know the future. And so 501c3s and nonprofits and private citizen engagement is the only way to ensure long-term continuity of programs. And so I just want to point that out. I think that makes a difference in the train of thought.
Absolutely. Dr. Bryce.
I think one of the things the very first time we met, one of the things that we talked about is maybe bringing those individuals or those entities in that we're going to subcontract to see, you know, how prepared they would be if we go that route, because many of them.
I have a concern, I know I shared it with you by email,
Right.
that we have to be very careful that we don't give a group a head start. Since we did pull those proposals back, we want to be sure that we don't give the two groups that did propose more of an advantage over maybe a group that didn't propose in the past and decides that they want to go ahead and send a proposal. So we really need to.
Yeah, not only that, this is gonna sound crazy,
Right.
but I'm not sure that the law, even if somebody said, I wanna do it anyway, I want to talk about all this, I don't know that the law would allow them to do that for this reason. The reason for RFPs is everybody can make their best, proposal. And when you have what everybody else is saying out there, they've set a mark. Now, we may not get the best deal. Everybody knows what it is. And so I'm not convinced that even if they wanted to, they can win.
But that puts us in a bad position because we don't know if these people are actually, you know, ready and capable to take over. I know in some cases, they put in the bid because they didn't want the services to go away, but that doesn't mean that they were ready to take it over and run the next day with it. And I think that that's where, you know, that's putting all of us as the board trying to make these decisions in a bad position because we don't know if they're ready to go.
Leanne, did you have a comment to that?
Just a part of our proposal process on any contract, and it could be doing the pavement at the airport or its parking garage. That's what staff's job is to assess that based on the terms of a specific grant and then make a recommendation to council. And that those recommendations come from the experts in that field, not from the budget guy or the city manager, but from the engineer that's airport director, health department director.
So is some somebody from, the public health going to be part of that that decision-making?
The
Just-
nurses that work in those areas and Bridget and her staff are the ones who will analyze
Okay.
the proposals to be sure they meet grant deliverables. The rest of us really don't know enough to be able to
Right.
make that assessment.
Okay.
Good, we're nearing the end. Are there any last questions or comments on this section? Yes, Dr. Verma?
Thank you. I think that it has been very informative. My suggestion is that whenever we review Dr. Chipro's resolution, there should be two. One short-term, how we salvage our current situation and how we get the best of it. And the second one, I think the city council should look for the long term, because suppose the grant goes away, so do we abandon these services? So city council should look at long-term solution also.
May I respond to that?
Yes, Jim?
The
Okay.
problem the city council has is one council cannot bind another council. That's where the rub comes. This council, I'm sorry, by law, this council could decide to make a long-term look and a long-term commitment. The next council gets elected next May and all bets are off.
Is there any accountability of anyone that can make long-term
You can't bind a government long-term, just like they're saying they're cutting spending 10 years down the line, the federal government. That's never, those things don't happen. You have to go city council to city council, government to government. It's
So
like
it can't be done. The Allen Henry pipeline wasn't just one council's action. So it can be passed from council to council.
Well, that's a contract that happens to last a little bit longer, I believe, is the reason that can be done.
And when debt is issued, and that debt is backed by the full faith and credit, and there is a provision for locking that in the state constitution. But debt is the only area where anything is bound going into the future.
And that is for infrastructure?
Yes, sir.
Infrastructure.
And all contracts with the city are written subject to annual appropriation, so there's always that. It always allows the next council to make a decision because those are the folks elected at that time.
Maybe we should keep re-electing the council till they find a solution.
In fact, Dr. Carr, there's also, a provision in the Constitution that says that basically you can't go fund something unless you either have the money in a sinking fund. If you don't have that, you can't go do it. Well, when, appropriation is there, then you go into a long-term contract. Because that then, keeps us from going afoul of the Constitution.
If somebody wants to come up with $5 million grant to establish something, then I think we would be able to do something. But in lieu of the fact we don't have money other than depending on grants, it's short-term, no matter how we look at it. Going on to the next section, we will have Bridget Falkenberry, Health Director, Leanne Dumbold, City Manager, Immunization, STD Services. This applies to two questions that were answered at the last meeting and additional information you're going to provide to us.
Thank you. So I'm gonna start with sexually transmitted disease clinic. The services that are provided are on tab T, page 190, and that is the statement of work that we are bound to when we receive the grant. These are the grant deliverables that I've been talking about all along. I'm not gonna go through each and every one of them, but I am gonna hit the highlights, and the main thing that grant funds is testing and treatment of syphilis, gonorrhea, and chlamydia, educating patients when they're in the clinic, giving the state disease intervention specialist first priority. That means when the state receives cases and they are actually working to try to find partners and contacts, they bring them into our clinic for testing and treatment, and we have to give them first priority in our clinic. We have to have SCAT RPR tests available. That's rapid plasma reagent, and if you ask me how that works, I don't understand that, but I know that it is a quick test for syphilis. We have to, anybody that does the grant has to have that capability. And part of the grant deliverable is to see all patients regardless of ability to pay. And I know there's some concern that people will be turned away due to inability to pay, but that is a grant deliverable that we will still, the city of Lubbock the document that Dr. Carr handed out, that it specifically mentions that local health departments can meet the goals that were listed by subcontracting services out. Okay, next is immunization services. And this is, you can find those service requirements on tab T, page 199. And that is the work plan for the grant that we currently go by. The services include program planning and evaluation, vaccine management, that's the storage and handling of vaccine and assisting the Texas Vaccine for Children's providers with their vaccine, making sure the stock is rotated, some of that's been mentioned before. Registries, that means data entry and M-Track and TWICEs. Those are databases that hold shot records for adults and children. Texas Vaccine for Children